Thank you very much, everyone, and welcome you all once again. And I'm really thrilled to be here because we had at the Kigali HPV Summit a few days ago, and most of us were together, and I'm happy to see you in Addis. And for those of you coming from the global community as well, welcome you all. So I will take you through the short presentation because much has been said about the Ethiopian experience. I will just pick the most strategic points. So this is the outline of the presentation. My colleagues has been said much about how we educate and how we really made tailored service delivery. So for those of you, perhaps you don't know the background of my country, we are 105 million plus based on the CSA projection we have, and we have 11 region, 2 city admin, in total 13. This is for the administration purpose, and we have 1,000 plus woredas. That is the lowest district for the administration, and 83% of the community, the population is living in rural setting, where that's why Ethiopia is really championing the health extension program, reaching the community, reaching the district. So the area square, Ethiopia is one of the big country and the second populous in Africa next to Nigeria in eastern part of, in the whole of the continent, and in eastern part of Africa, I think we are the one leading the eastern part of the region in terms of, the size and also the population. So we have close to 4,000 hospital and also 3,700 health center. We have more than 18,000 health posts. This is really for you to clearly understand how we have the health tier system is in 3 ways. And we have 14 national and regional lab. And also this is very critical, for the immunization system and as a whole for the health system. And we have the National Pharmaceutical Distribution Agency from the national hub to down to the sub-national hub. We have a total of 20 hubs. And you can see immunization is evolving. And we provide the immunization service in more than 20,000 facilities. So I can say close to 95%, 90+% of the immunization program is grounded at the primary health care unit. So you can see how my country is evolving, for the immunization program. The commencement has been done in 1980, that this is 4 decades plus. And specifically, I would like to draw your attention for HPV. We started in the year 2018, just before COVID. You remember, we are still in the midst of COVID. So we have a total of 12 antigen, which is being provided in our routine immunization. So this picture shows you that how immunization is one of the weapon, I can say, the weapon and the strong public health intervention for the reduction of preventable maternal, neonatal, and child mortality in general. So it has a lot to do, and it has a direct implication for, the maternal mortality and neonatal and infant, under 5 and infant mortality reduction. And also you can see the coverage. As the coverage increases, the mortality and morbidity decreases. So this is also one of the unfinished agenda for SDG 2030. That's why we are trying to evolve and, put much attention for the immunization program. So the disease burden, I think, about the cervical cancer. This is one of the deadly diseases next to breast, on the top, and the second cancer in the country. The top is breast cancer in terms of the prevalence. But when you see still cervical cancer is still the highest cause of mortality. And also the risky age groups are 15, you can see 15 age greater than 15 are the risky groups. That's why the HPV has been, commenced for 14-year-old girl in Ethiopia. We haven't yet achieved the multi-age cohort. And when you see the cervical cancer case per annum, it's more than 7,000, which is really, one of the public health attentions. That's why we have the strategy to eliminate cervical cancer through immunization, HPV, and earlier screening, and earlier bringing them to the care and comprehensive care and treatment service as well. So specifically for HPV, perhaps you had at this slide, maybe yesterday or today when Gusto has presented. We try to reach out our girls since the start, 2018 to 2021, and we are in a better condition because the COVID is here and there are also local conflict, and also, the droughts has also affected the lowland part of Ethiopia. So we were in a triple burden. So Ethiopia is one of the best showcase for the global community, how we try to mitigate and, connect the two nexus, development function and the emergency and humanitarian response together. So we haven't, stopped the essential function while COVID is one of the global agenda, and also some of the humanitarian condition happened. So you can see we reached out to vaccinate 4.1 million girls since the start, at least one dose, and 3.1 million has been also vaccinated for the second dose. 4.8 million for the first dose and 3.1 million and above for completely vaccinated. So this slide shows you that the disaggregation in the subnational region, in the region or subnational areas, so that you can see still we are trying our best to respond for the equity issue, because we are not dealing about the subnational, what at the end of the day, we have to make sure that every girl is in every corner of the country protected, get vaccinated, whatsoever the platform we have. Our platform is the school-based, which we have 85% of coverage for the school. Girls are in the school, but still in a pastoralist community, they're out of school. So we try to reach out through the mobile approach and through the campaign. So one of you can ask me later on what's happening in the northern part of Ethiopia, because we give due attention for vaccine preventable disease, particularly causing outbreak. So that this is the way how we mitigate and try to respond for the emergency situation, because measles is one of, perhaps one of the proto example to show us this is one of the vaccine preventable disease. Perhaps it also causes a devastating situation like COVID and others. So that's why we give due attention for those causing outbreak, and also perhaps HPV might give us some time to think about, and because once the school opening is resumed, once the situation is getting over, so we will try to mitigate in that area as well. So this is how we try to address the equity out of school girls, particularly in pastoralist community, using the health facilities and also outreach modalities that we try to catch up. And then, so this is how we can try to respond for the equity. So vaccine delivery, I have already talked about this. The school base, out of school can be reached out with the outreach and also with the campaign. So whatsoever the case, our service delivery modality is school-based, and also for out of school using the mobile health team. So we try to address. So facilitators and achievements to the standards for the sustainable coverage, I can say planning and coordination is very, very critical. And prior to that, the political commitment is very powerful, because at the end of the day, without the political will, you cannot proceed with a new program. So that what really matters at the very beginning is how we can shape, and table for the influencers, including the political, leaders, how you shape the agenda, how you table them, and also how you can try to influence them, how you try to bring every actors, including other sectors. HPV is one of the showcase how we try to influence other sectors, like the Ministry of Education and also Ministry of Women and Social Affairs. So without them, it wouldn't happen like that. So our coverage is very, very, very quite high. So that this shows that how we table this agenda for the Ministry of Education and other sectors. They are doing their best. This is one of the showcase how the Ministry of Health is really trying to bring other sectors to do their best for health in all policy. Because we are trying our best for our citizen to make every citizen healthier for the productivity and, for the prosperity, our journey we have started. So that the other sectors should do their best for health, because without health, education will be a dream. productivity will be a dream, and also prosperity will be a dream. So to make this dream reality, bringing other sector is very critical. The rest technical issue has been already discussed by my colleagues. So planning and coordination, very, very critical. We use the top down, top up and bottom up, and we try to support everyone. We try to engage the regions, every, stakeholders, including the religious leaders, clan leaders, and also trusted messengers in the community, because Ethiopia has three contexts: urban, agrarian, and pastoral, so that we cannot use the modalities that we use in agrarian context. Perhaps in the pastoralist community, the clan leaders and religious leaders are the one who are really influencing the people, so that trying and bringing them to the, with this agenda is very, very critical. And so trying to use the media people's other elites are also very important, because at the very beginning, we were challenged. If you remember, there are, elites, they were really antagonizing the HPV, because this is, the age is by itself is pretty sensitive. Something you deal with adolescent girls by itself is pretty sensitive, culturally sensitive. The modality is in the school. So that because of that, we try to mitigate by bringing everyone with engagement, Once you engage, it will be easier for them to support the ministry, So that's why we try to reach out our girls and to reach to this milestone. So intersectoral collaboration, I have already, talked about that. Perhaps we also try to engage our agencies, Without supply, there is no program. So that the supply agency, the regulatory agency, and the technical arm of Ministry of Health, that is the Ethiopian Public Health Institute, for evidence, these are the actors under the Ministry of Health. They are also on board. They have, we tabled this agenda for them. And also the media peoples, not only the national media, the local media also used. And also the former First Lady was the one, taking the lead. She was championing this program. So I much appreciate, the former leadership, how, we have to always recognize what has been done so far. 1 minute. I think demand promotion has already shown for you. This is how we try to engage the regional, leaders and also stakeholders as well. I think much has been said. I want to show you one very important picture. Ethiopia has a very different diversity. This is one of the regions that we call Gambela, how we deliver the vaccine and all the supplies. You can see this is the boat. And, even even within the region, there are many hard to reach areas that we use every modality for the last mile delivery. Airshift, perhaps if there is any security challenge, we use the boat, we use the ground transportation, whatsoever. Even we use camel in the pastoralist community to deliver, the vaccine and logistic. So monitoring and supervision has been also, this picture speaks a lot, how we try to engage excellencies, the political leaders in our supervision and monitoring intra-campaign. So His Excellency, the State Minister, was the one, we were checking the private school and also the public school on the same day, how the vaccination went out. So about the coverage that what we have. Okay. Maybe one very important picture at the last. So you can see the diversity of the topography of my country. You can see the health extension worker at the top of the hill. It's not easier to reach to this level. So we are trying to, respond for equity. Wherever the kids or the children or the adolescents are there, this is our duty to reach out. So I would like to really convey my gratitude for our selfless health workers, health extension workers, everyone, the leaders and technical team as well. So perhaps I think for the interest of time, let me stop here. Thank you very much indeed for the chance. Sorry.